Thank you, Kishore sir, for that introduction. I would like to thank George sir for giving me this opportunity. And let's move on to the topic. Good evening, respected teachers and dear friends. Today's topic, as Kishore sir has rightly pointed out, is another important virus, that is Parvovirus B19. And what is its clinical relevance in the immunosuppressed? So when you think about Parvovirus B19, the first impression that comes to our mind is that of a slapped cheek appearance, that is fifth disease or erythema infectiosum. So Parvovirus is a small non-enveloped single-stranded DNA virus. It is not only seen in humans, there is canine parvovirus as well. But human parvovirus, this B19, it has multiple genotypes, B19, LA-like, and V9-like. And the importance of parvovirus B19 or PVB19 is that humans are the only known host for B19. And it's an autonomic virus. It does not require the presence of a helper virus. And it has a specific cellular tropism. That means it has an adherence to, it has an affinity to the erythroid progenitor cells. So it is a very common virus. It's seen worldwide. It usually gets acquired during childhood, and there could be continuous infections throughout adulthood. People may get infected throughout during their early adulthood. By the time we reach adulthood, around 70 to 85% would have had past infection, and many may not even recollect about such an infection because it comes like a transient flu. Only parents might remember that child had a slapped cheek appearance or a rash like that. Then transmission is mainly by inhalation of virus in aerosol droplets, and infection can also be transmitted vertically from mother to fetus, and less commonly through transfusion of blood products, bone marrow transplants, and solid organ transplants. Coming to the structure of the virus in a nutshell, it has two viral proteins, VP1 and VP2, and a non-structural protein called NS1. This VP2 is important because it facilitates the viral attachment onto cells. And then the NS1, it is a multifunctional protein. It has many regulatory functions in the viral life cycle. It is important because it helps in it is the main protein which is important in the target cell cytotoxicity, and it activates pro-inflammatory cytokine promoters. So after gaining access to the human host, this B19 targets the erythroid progenitors in the bone marrow. That is why it is called erythrovirus. Parvovirus B19 is also called erythrovirus because it has an attached affinity to the erythroid progenitors. And why is it so? It is because of by binding to the glycosphingolipid globoside or GB4, also known as blood group P antigen. But this P antigen, one important aspect is that it is present abundantly on the erythroblast, but it is present also in the non-erythroid cell types. But to act, although P antigen is necessary for binding the virus to the cell surface, it is not sufficient for entry and replicative infection. It requires two co-receptors. One is cellular co-receptor called alpha-5 beta-1 integrin, and another one is KU80. These are the two co-receptors which are required for the successful function of this virus to get into the cell. Then the cell death ensues by either lysis or apoptosis mediated by the NS1 protein. And in normal infection, there could be intense viremia and later on developing specific IgM antibodies within 10 to 12 days after infection, and later on IgG antibodies. Both humoral and cellular responses have been understood in this pathology. And then as in many viral infections, this is the basic process which occurs leading to the cell lysis. And the 5 well-established syndromes associated with Parvovirus B19 are the most common fifth disease or erythema infectiosum in children. And mainly it is a malar rash. The typical malar rash is seen only in children, and it is seldom seen in adults. And mainly adults present as arthropathy or arthritis affecting the small joints of the hands, wrists, knees, and feet. And in those with chronic hemolytic disorders like sickle cell anemia, hereditary spherocytosis, thalassemia, or even iron deficiency anemia, it can present as a transient aplastic crisis. And in fetal infection leading to non-immune hydrops fetalis, intrauterine fetal death, miscarriage, etc. can occur. And in immunocompromised individuals, it can cause pure red cell aplasia. So as I said before, in a normal immunocompetent person, if he may not even remember having an Parvovirus B19 infection, or it can have a transient aplastic, which could go unnoticed. But in those with chronic hemolytic disorders and those who are immunocompromised are the two important sets of people who can get severely affected due to the parvovirus infection. So it all depends upon the host characteristics, whether it is a healthy host or a host with comorbidity. So Parvovirus B19 in a healthy host, as I said, it is self-limited event. There could be transient reticulocytopenia. There could be no clinical anemia because we have a sufficiently long red cell lifespan of 120 days. So it may, within the short span of viral infection, it may get unnoticed. And rash and this arthralgia could occur due to the immune complex formation, indicating resolution of viremia. And in a host with comorbidity, it becomes complicated because it can develop a plastic crisis because the short red cell lifespan and the prolonged viremia from immunosuppression can cause pure red cell aplasia. And this all can lead to other fatal issues like cardiopulmonary burden, heart failure, etc. So this is this graph shows the clinical features, hematological changes, viral DNA, and antibody responses. Here you can see that it is a biphasic response. It's the first, the initial spike, which shows the patient's symptomatic flu-like picture, where the fever, chills, headache, and myalgia are predominating within the first week, first 1 to 2 weeks. By the time of the patient reaches around 10 days, 10 to 14 days, the IgM viremia comes down, and IgM antibodies have already started forming, and then IgG antibodies take over. Then the patient develops a second spike, that is, it is a biphasic illness, second spike of rash and arthralgia. This is mainly due to the immune complex formation, which should have formed. And this, the hematological changes, you can see here that there is a transient drop in the reticulocytes. And by the time the patient reaches the second or third week, already it has come, the hemoglobin and reticulocyte would have come back to normal. And this by B19 DNA in the time of this viremia, and it remains detectable, and the PCR through PCR. And this IgG antibody can persist for a long time. So Parvovirus B19, what does it do in the bone marrow? So in the bone marrow, you can see the multipotent hematopoietic stem cell. Then the Parvovirus B19, the target is the pro-erythroblast or pro-normoblast. So I said that P antigen along with the two co-receptors, that is alpha 5 beta 1 integrin and KU80. They are the two co-receptors which help in the virus intrusion into the pro-normoblast. And then it deviates from the normal pathway and it forms a giant pro-erythroblast, and where there is a multiplication of the virions inside the cell. And this, along with due to the NS1 action, it causes virus cell lysis by either apoptosis, cell lysis and apoptosis. And that's how there is a disruption of the erythropoiesis by Parvovirus B19. So this Parvovirus B19 infections are the most contagious during the phase of active viral replication. Usually, the viremia lasts for 5 to 10 days, and usually immunocompetent patients may not have much symptoms except for a flu-like illness. The 25% patients will be completely asymptomatic, and another 25% may have some arthralgia and arthritis, which may also be self-limiting. So in a immunocompetent person, there will be, you can see that there is at the peak of this red shows the red block shows the viremia, and this black one shows the reticulocyte counts. This is the hemoglobin, and this is the platelet. So not only the HB hemoglobin, the only other cell lines can also be involved, but there won't be much reduction compared to the erythrocytes. So here you can see that when there is a peak in the viremia, reticulocyte count drops drastically, and then by the time of the viremia comes down, it comes up and comes back to normal. And hemoglobin also closely follows the graph. And this shows the biphasic symptoms of the patient, biphasic nature of the illness. So this viral DNA can be detected in blood, bone marrow, and infected organs using PCR, and is also detected in asymptomatic. So there could be patients with asymptomatic patients who can have they can have presence of DNA PCR, which is not significant. So the detection of viral DNA with clinical findings, that is anemia, severe anemia, not with very low reticulocyte count. That is inappropriate reticulocyte count. Very low reticulocyte count is in an appropriate setting of an immunocompromised patient or a patient with a chronic hemolytic disorder is the scenario where we have to think about an active Parvovirus B19 infection. So if the serology or PCR are negative, but since even if the then clinical suspicion is high, what we can suggest the bone marrow examination using immunohistochemical staining or in situ hybridization, which is very helpful in establishing the diagnosis. In immunocompetent, we don't have to treat specifically, only supportive care is enough. But severe anemia, not responding to transfusions in immunocompromised or hemolytic disorders, IVIG is shown to be effective. And there are many literature about this, but IVIG has shown to be universally effective in these cases, and 400 milligram per kg per day. Dosing is different in different literature, but 400 milligram per kg per day for 5 days have been the recommended use in many studies, and monitoring with retic count and hemoglobin response. So most of the symptoms, as you can see here, are mainly like a typical flu-like illness. But there are some other issues like myocarditis, pericardial effusions, then neurologic. There are many uncommon cases, uncommon disease associations with parvovirus B19 infection, which are yet to be proved. So transient aplastic crisis, which can occur, which is a temporary suspension of erythropoiesis, can occur in sickle cell disease, hereditary spherocytosis, and sometimes in iron deficiency anemia also. And it is more common with genotype 3 of erythroviruses. And patients can present with pallor, weakness, lethargy. And this can transient aplastic crisis in patients like sickle cell disease. It can be rarely fatal also, leading to cardiac failure, CVA, and acute splenic sequestration, etc. And it is usually self-limited, and because once the viremia declines and the infection is controlled resolved, patients will the red cell production will return to baseline. And in an immunocompetent patient, since he develops an IgG antibody, he acquires only once an infection, and after that there is no documented reinfection, is very unlikely. But in an immunosuppressed host, because of the different problems are, one is the inability or decreased ability to mount an immune response to clear viremia, or the chronic or, so what happens is there will be a chronic or reactivated parvovirus B19 infection, and this can occur in an immunosuppressed individual, leading to chronic pure red cell aplasia. It's more commonly seen in leukemias, cancers, recipients of organ transplants, or congenital immunodeficiencies, or patients with advanced HIV. So peripheral reticulocytes will be significantly reduced, and if we do a bone marrow, we can see giant pronormoblast with large eosinophilic nuclear vacuolations. So immunocompetent host, in an immunocompetent host without aplasia, a negative PCR test does not rule out acute parvovirus B19 infection. So a negative PCR, we cannot rule out a parvovirus B19 infection, but the detectable DNA PCR also necessarily does not indicate an acute infection. So what we have to see is whether the patient has an appropriate setting with a clinical feature suggestive of parvovirus B19 infection. That is severe anemia with a very low reticulocyte count or hematocrit. So such an individual we should suspect having parvovirus B19 infection. And at the time of anemia, when the patient develops parvovirus B19, DNA levels are generally very high. And we can do either using the PCR test or NAT, or we can do a bone marrow study if other tests are negative. So anemia and parvovirus B19 infection depends on three factors, that is underlying condition, RBC lifespan, immune response to the virus, effect on, and what is the effect. So if patient does not have any underlying conditions like hemolysis or immunodeficiency, you know that RBC lifespan is 120 days. And such a patient, the immune response is normal within 10 to 14 days. And normal HB hematocrit will be maintained. Even though there could be a small drop during the infection, it comes back to normal within 14 days. Then a patient with chronic hemolysis, the RBC lifespan is very much low, so 5 to 10 days. So normal immune response, but immune response is normal, but there could be transient aplastic crisis or acute transient pure cell aplasia. But in a patient with immunodeficiency, even though the RBC lifespan is normal, he cannot clear the virus and he cannot mount an adequate immune response. And such a patient is at risk for chronic pure cell aplasia. So when we consider an immunocompetent and immunosuppressed patient and parvovirus and kidney, the three scenarios where we have to encounter kidney problems in a parvovirus patient will be, one is acute glomerulopathy, then severe anemia in an ESRD patient, or a renal transplant scenario. So when I check for parvovirus and kidney, there are mostly the case reports. We couldn't, only very few case series reports are there, but I would like to share whatever literature I got. So this is one journal from an article published in AJKD, Parvovirus B19 and kidney. And so these, what is the effect of parvovirus on kidney, and what is the reason why kidney gets affected? So it can affect in normal person, in an immunocompetent person as well. And there are two different types of scenario where kidney biopsies were done in parvovirus B19 infection. One is when a patient who presents with an acute flu-like illness with urinary abnormalities which are persistent, like our nephrotic syndrome or nephrotic range proteinuria, or patient with deranged RFT. Or that was one type of presentation where patients were subjected to renal biopsy. And such cases, what is the and so the reports were like there are varied histologic patterns which have been reported in association with infection, like collapsing glomerulopathy, nephrotic syndrome, lupus-like, membranoproliferative, and many times it was post-infectious glomerulonephritis. So, is it because of the cytopathic effects of the P antigen, or it is because of the immune complex deposits? Further studies are required for that. And there are many developed autoantibodies, like autoantibodies to cardiolipin, phospholipids, dsDNA, which have been reported during parvovirus infection. So these are also implicated as leading to preformed circulating immune complexes or in situ deposition. And direct infection of the glomerular endothelial cells also have been proposed as a mechanism of renal injury in case of TMA and vasculitis. And in allograft kidney, if we do parvovirus B19 infection, one thing that we have to notice for diagnosis of parvovirus B19 infection, we don't require a renal biopsy in an allograft kidney. Most of the time, it is the severe anemia which glitches the diagnosis. So DNA PCR would be enough. But if there is a persistent infection, only limited number of cases where allograft kidneys are the biopsies are done for parvovirus B19 infection. But some case reports have shown that thrombotic microangiopathy and collapsing glomerulopathy are the main histopathological features in PBB19 infection. So renal transplant recipients, they are highly susceptible to parvovirus. Could be increased use of induction therapy and sustained long-term immunosuppression would be the reason behind that. And they're all presenting as erythropoietin-resistant severe anemia and inadequate host immune response, inability to clear the virus, and reactivation of infections when immunosuppressants are high, like the initial part of transplant or whenever there is a rejection, we have to increase the immunosuppressants. So that is the time when patients get more prone to severe parvovirus B19 infection. And that time, if the patient had presents with rapid onset of severe anemia with inadequate reticulocyte response in the absence of other causes of anemia, we have to definitely think about parvovirus B19 infection. So the various presentations in various, as I said, acute nephrotic syndrome, post-infectious glomerulonephritis, collapsing FSGS, membranoproliferative TMA, nephrotic range proteinuria, even lupus-like presentations have been noticed. Then endocapillary proliferative glomerulonephritis in parvovirus B19. Then even pediatric kidney transplant recipients, parvovirus B19 infection case reports are there. And one case series which I would like to present in this platform is parvovirus disease post-renal transplant presenting as refractory anemia. This is from Rajapurta Center. It is a single center experience which was published in April 2021 in Kidney International. I will go to the details. This is a renal transplant recipient transplanted from 2013 to 2020 having persistent anemia were evaluated after ruling out usual causes of anemia. And they were checked for parvovirus by PCR and bone marrow examination. So out of the 71 patients tested for parvovirus, 19 were PCR positive. One patient's PCR was negative, but marrow was positive. So there were 20 renal transplant recipients, either PCR positive or marrow positive, which was diagnosed as parvovirus. So in their study, the median time to onset of disease was 39 days post-transplantation. And mainly the presentations were fever, generalized, apart the clinical, the presenting complaints were fever, generalized weakness, then dyspnea, myalgia, etc. And the mean HB was so low, that's 6.4. And along with that, leukopenia around 20% and thrombocytopenia 10%. And rejection is seen in 9% patients. And this is the clinical picture. And the graft dysfunction was observed at the time of parvovirus B19 disease in 10 patients. Then what they could do was the reduction in immunosuppressant therapy was the most commonly used modality of treatment. Then IVIG, and then Paxil transfusion and erythropoietin therapy were also used. Then 2 patients had their graft loss and 1 patient had recurrence and 1 had a non-recurring graft function. So this shows that there is the time of parvovirus B19 when the HB dropped to almost around 5 or near to 6. So these patients had a baseline hemoglobin of 9.8, and then by the time the HB dropped to 5.6, they thought about infection of parvovirus B19. So that is the situation where we consider, that is the time when we consider such patients that having the clinical setting where we think that it could be due to parvovirus B19. So by effects of this is another study published in a series of 3 cases. Which was published in another International Journal of Angiology. That's effect of parvovirus B19 infection renal transplant recipients. A retrospective review of 3 cases. So this was this all are living related live donors transplants. With induction protocol was same, basiliximab steroid, and immunosuppression protocol was almost similar, JAK, MMF, and prednisolone. And these patients, you can see that time of parvovirus infection post-transplant was by 8 weeks, 8 to 11 weeks. And then report showed severe anemia with hemoglobin 6.6, and retic count was very low, that's 0.3, 0.2, etc. And all these patients, we have to, the treatment was same. Treatment is detection of parvovirus, positive PCR, either by or bone marrow study. And some patients had a co-infection also, CMV, PCR positive, EBV antigen positive, and the lowest hemoglobin was 6. And you can see that there is not much difference in the creatinine. There is not much difference. The baseline creatinine was around 1.3, 1.4, and the highest creatinine had come up to 2.2. Treatment was with IVIG infusion and decreasing the immunosuppression and all 3 units of PRBC transfusion. So this patient was on tacrolimus, but some reports have shown that switching from tacrolimus to cyclosporin could be effective in some patients, but that is not proven. So IVIG infusion, Paxil transfusion, and decreasing the immunosuppression are the 3 modalities of treatment where we can give. And erythropoietin is also could be continued, even though it is somewhat controversial. Then you can see that HB post-treatment has improved to around 12, almost doubled, and the creatinine had come down to normal or baseline, and the sustained hemoglobin improvement after 4 weeks was persisting. So this is about how transplant patients can present, and with treatment how they can improve. So when we consider parvovirus B19, the first thing that we consider now, apart from the transplant scenario, is the HIV positive or retroviral positive cases. So that is one important feature where almost all the retroviral positive patients are the main group where they can get parvovirus B19 infection. And when we this is a study done in South Africa. This adult pure red cell aplasia in a 9-year review. So pure red cell aplasia could be primary or secondary. And this you can see that infections, but 26 patients had HIV, were HIV positive, and 12 were parvovirus B19 positive. And all patients with parvovirus B19 were HIV positive. So all these 12 were retrovirus positive. So I have highlighted the studies, this parvovirus B19 PRCA. In this patients, earlier we had seen that treatment is with IVIG transfusion and all that. But here, spontaneous remission of a parvovirus infection or anemia once the patient was started on combined antiretroviral therapy. So, initial treatment with antiretroviral therapy has led to improvement in HB hemoglobin and resolution of symptoms of parvovirus B19. But most of the patients, that occurred only in 2 patients out of these 10, and other patients required IV immunoglobulin. But these 2 cases, they improved on with continued combined antiretroviral therapy only. Only with antiretroviral therapy itself, there was a spontaneous remission. And here also bone marrow features of parvovirus B19. There were 2 patients. There one patient improved with retroviral therapy and antiretroviral therapy, and then one patient improved with IVIG. And this is another in the study which was published in Transplant Immunology in October 2022. So it is a parvovirus B19 infection kidney transplant, a retrospective study done in China. So it is a number of patients were on around 118, and here between September 2020 and May 2021 were analyzed. And we can see that from the earlier studies that there is a different timeline where parvovirus infection can occur in different studies. But in this study, to exclude the possibility of donor infection caused by causing B19 virus positivity, all donors were tested and proved to be negative for B19 virus. So they did the donor screening for parvovirus B19, and all the donors were tested and were tested negative for parvovirus B19 infection. And what they did is for all the recipients, the first plasma sample was obtained before transplant, and then samples were collected meticulously, like every week until 1 month, and then per month until 6 months generally. So to identify the point of time when the patients become positive. So if a sample yielded a positive B19 DNA result, then they followed up DNA weekly until it turned negative. So even if it is a positive B19 viral DNA result, it may not indicate an active infection. Mean like case patient may not be symptomatic for them to treat. So the diagnosis is as by progressive severe anemia, as we said earlier, and with a PCR or positive serologic assay by IgM antibodies. Then mostly it is by the PCR test, and patients were on routine immunosuppressive regimen with induction protocol was either ATG or basiliximab with MPS, and and maintenance was with tacrolimus or cyclosporin, MMF or prednisolone was the maintenance therapy. So when we think about the kidney transplant, the 1 month post transplant, for the first month we think about the bacterial infection as most commonly, and then comes the viral infection. So in this study, this graph, you can see that almost within the first 2 weeks itself, most of the patients have become positive for B19 virus infection. So the first 2 weeks itself, they have become positive. And this is just to highlight the fact that it is not only a single IVIG can cause a resolution of symptoms. So you can see that this is the red graph is the IgM. Then you can see that, sorry. IgG is the blue one, and black is the DNA, and the green is the hemoglobin level. And most of the time, this IVIG it is given at the peak point of viremia, and then there is a gradual resolution of viremia to almost within normal limits. And then by that time, hemoglobin also starts improving, and there is a persistent improvement in the hemoglobin level. But you can see that here this patient has, even though viremia has come down, the persistently low hemoglobin is seen here, and they had to give a second dose of immunoglobulin, IV immunoglobulin. So this can happen in post-renal transplant, where patients can have inadequate response to IV immunoglobulin, where there are some reports where patients require, with monitoring, if there is an inadequate hemoglobin improvement or inadequate reticulocyte response, where the treating unit has to supplement IV immunoglobulin periodically. So that can also happen. It is not like with one patient, as I said earlier, immunocompetent patients, it may be a one-time infection, it may not recur. But in immunocompromised patients, there could be inadequate response to IVIG, and there could be reactivation and reinfection, causing this pure red cell aplasia into a chronic one. And the risk factors for this study, they had compared the risk factors about B19 positive, B19 negative patients and the relative risk about the immunosuppressive therapy, and each molecule independently, that is basiliximab. And it had a 1.19 relative risk of infection of parvovirus B19, and ATG also had 0.8. And so basically, then both these are statistically significant. And TAC had 0.64, and cyclosporin also almost similar, 0.69. But some studies have shown that switching from tacrolimus to cyclosporin is better for viral clearance. And when the induction therapy with basiliximab and ATG, when we compare, the relative risk of B19 infection is more for either MPS plus basiliximab, that is 1.19. And even with ATG, it is relative risk is high, 0.8, but more for basiliximab. But both these are statistically significant findings. So we can see that both all these are predisposing factors or making the patient more vulnerable to infection with parvovirus B19. So the highlights of the study was B19 virus infection can occur within even 2 weeks after kidney transplant, and the prevalence was around 10.17%. Can lead to anemia, sometimes reduction platelet, then other organ function dysfunction can also occur. Then so whenever there is a severe anemia or decrease in reticulocyte count the first 2 weeks after transplant, they always have to watch out for B19 infection. And basiliximab was an independent risk factor for B19 infection. So in immunosuppression is a major risk factor. We cannot avoid in renal transplant recipients or other solid organ transplant recipients, but it's a major risk factor. So we always have to be highly vigilant, like after transplantation or after treatment of rejection, whenever there is a hike in the immunosuppression, that is the time when patients can develop more vulnerable to such opportunistic infections. And parvovirus B19 is we can diagnose by there is a sudden severe anemia and with inadequate retic count. That time we have to definitely check for parvovirus. Parvovirus as such is not, we were not considering it as a dreaded virus like BKV or CMV. But unexplained severe anemia and inadequate and unexplained severe anemia in a post-transplant patient could be very debilitating issues leading to multi-organ dysfunction, like cardiac failure or other issues can occur. So always, if a patient with severe anemia with inadequate red cell count, we should always consider testing for parvovirus B90. So the major factors, risk factors, will be the inadequate host immune response. When you consider even immunocompetent versus immunocompromised patient, the inadequate host response, incomplete clearing of the virus, then reactivation and reinfection. When especially when there is a hike of immunosuppression, they will be the major risk factors for getting such infections. And usually this IVIG transfusions and supportive monitoring will be enough for most of the patients. But as I said earlier, sometimes some patients may develop repeated infections, and such patients may require prolonged IVIG therapy. That ends my presentation. Thank you.